Hi, this is Randall Ruta. I'm President and CEO of the American Autoimmune Related Diseases Association. Dr. Diamond, I believe it's 2 o'clock and we're ready to go.
Okay. So I'm Betty Diamond, and I'm very pleased to welcome you, and there are more than 4,500 of you, to a national briefing with the Center for Disease Control and Prevention on the coronavirus COVID-19, and to discuss how it affects people with autoimmune conditions. This national meeting is being hosted by the American Autoimmune Related Disease Association and the National Coalition of Autoimmune Patient Groups, a group of 40 national disease-specific organizations. I serve as head of the Feinstein the Center for Autoimmune, Musculoskeletal, and Hematopoietic Diseases at the Feinstein Institute for Medical Research, and I chair ARDA's Scientific Advisory Board. ARDA and the coalition decided that, or really understood that COVID-19 is a particular threat to people with autoimmune diseases, or poses particular challenges to people with autoimmune diseases, and that there was a real need to be able to speak to you directly and have physicians and the CDC speak to you directly to help answer your questions about what this pandemic means for you. So you're going to hear from 3 physicians, Dr. Georgina Peacock, who's the CDC COVID-19 Task Force leader and director of the Division of Human Development and Disability, who's going to begin the conversation. And then you will hear from Dr. Aline Charabati, who's a gastroenterologist and director of the IBD Center at Johns Hopkins Sibley Memorial Hospital, and Nancy Carteron, who's a rheumatologist at University of California, Berkeley, describing, and they will describe their experience with patients with COVID-19, and Dr. Eric Chow from the CDC has also joined this conversation. He's in the Medical Care and Countermeasures Task Force for COVID-19, and he will be able to answer questions also. I will also tell you at this point that many of you submitted questions, and that ARDA and the coalition partners are committed to answering all of your questions. Answers will be available on the ARDA website, which is www.arda.org, and it will take some time to go through the numerous questions that have been asked, but they will all be answered, and there, in fact, will be a transcript of this briefing available to you also. People with autoimmune diseases need to understand about COVID-19 and how you with autoimmune diseases can protect yourself and deal at the same time with your chronic illness during this pandemic. So, Dr. Peacock?
Thank you, Dr. Diamond. It's great to be here. So as you stated, I'm the lead of the At-Risk Populations Task Force within the CDC COVID-19 response, and typically work as the Director of Human Development and Disability in a different part of CDC. And I wanted to start out by acknowledging that for all of us, this is an extraordinary stressful time, particularly people who may be at higher risk for severe illness from COVID-19. And we're hopeful that today's call will help a little with answering your questions and helping you make a plan. So with that, I'm going to start out by providing some information about COVID-19 and then go into some more details. So if you can advance the slide again. So first, a little bit about coronavirus. This is a large family of viruses that cause respiratory illness, and it was first isolated in the 1960s. And the reason it's called coronavirus is because of the crown-like spikes that you see on the surface. And we know that coronaviruses can spread among animals and people, and then also people to people. And that's why we call this a zoonotic virus. Next slide. So COVID-19, which is the virus that is currently causing this pandemic, was first identified about 5 months ago. And this is a new virus, and so we still have a lot to learn about it, and we're learning new things every day. As a little bit of information on how it was named by the World Health Organization, the CO stands for corona, the VI stands for virus, and the D stands for disease. So that's how we came up with COVID. And as many of you may know, the first infections were linked to a live animal market, but the virus now, as you have seen in many reports, and are possibly experiencing in your community right now, that it's spreading from person to person. And we know that COVID-19 now is spreading very easily. It is in many communities what we call sustained spread, so that means that there is a lot of spreading happening in communities, and that means that sometimes people may not know who directly they got that infection from because it is present widely in the community. The next slide. So as of noon today, CDC has reported 239,279 total cases and 5,443 deaths here in the United States. And it has been reported in all 50 states, the District of Columbia, American Samoa, Marshall Islands, Palau, Puerto Rico, Guam, Northern Mariana Islands, and the U.S. Virgin Islands. So it's present in all parts of the United States now. Next slide. So the virus is thought to spread mainly from person to person and between people who are in close contact with one another, so within about 6 feet. It spreads through respiratory droplets that are produced when a person coughs or sneezes, and it may be possible that a person can get COVID-19 by touching a surface or an object that the virus is on, and then touching their own mouth, nose, or possibly their eyes, though we don't think that this is the main way that the virus spreads. Next slide. The symptoms may include fever, cough, shortness of breath, and there's a wide range of illness that's reported. So some people may have mild cold-like symptoms, and others have severe illness requiring hospitalization, and sometimes hospitalization in the intensive care unit. And as I reported before, it also can result in death. The incubation period is how long it takes from when you're exposed to the virus to when you start having symptoms. And for COVID-19, that's a pretty broad range, so it can range from 2 to 14 days. Next slide. So at this time, there isn't any specific antiviral treatment to treat COVID-19. We do have, or there are some clinical trials underway on an array of drugs that have been approved for other indications, as well as several investigational drugs that are being studied in several hundred clinical trials that are underway across the globe. This includes 2 approved drugs, chloroquine and hydroxychloroquine, and also 1 investigational agent, remdesivir. So right now, the standard treatment is supportive care to help people feel better and to manage the pneumonia and respiratory failure. Next slide. So COVID-19 is a new disease, as I mentioned before, and so we have limited information regarding the risk factors for severe disease. But based on the current available information and clinical expertise, older adults and people of any age who have serious underlying conditions may be at higher risk for severe illness from COVID-19. And you'll see here a listing that we do realize that people that may be at higher risk include those who are aged 65 years and older, those who live in a nursing home or long-term care facility, and those who have certain underlying conditions, particularly if those are not well controlled, such as chronic lung disease and moderate to severe asthma, severe heart conditions, severe obesity with a body mass index of 40 or higher, diabetes, chronic kidney disease, in particular those undergoing dialysis, liver disease, and immunocompromised conditions. Next slide. And so you'll see here some examples of people who may be considered immunocompromised, including those undergoing cancer treatment, those with bone marrow or organ transplantation, immunodeficiencies, end-stage HIV, prolonged use of corticosteroids, and use of immune-weakening medications such as biologics. And people who are immunocompromised may have reduced ability to fight infectious diseases, including viruses like COVID-19. And potentially people who are immunocompromised may also be infectious for longer. That's something that we have seen with other viruses, and so this may also occur with COVID-19. Next slide. So we did release a report about a week ago that looked at certain underlying conditions among patients with coronavirus disease that had been reported between February 12th and March 28th. And you can see here on the slides that what I'm featuring on this slide is not that entire report, but the information that we had on people who were immunocompromised and had COVID-19. So 53% of those that had been reported in this particular set of patients that had been reported to the CDC, 53% were not hospitalized, 24% were hospitalized but not in the ICU, 16% were admitted to the intensive care unit, and for 7% of those, we didn't know what the hospitalization status was. It wasn't reported. So that's just a little bit more information that we have so far on information about people who have underlying conditions in COVID-19. I'd encourage you to access this report if you want to see details on other underlying conditions. Next slide. So we do have some early data in a well-controlled but very small study that did not demonstrate that taking hydroxychloroquine and so we have some information on hydroxychloroquine and chloroquine. And we, as you know, this is an effective treatment for rheumatoid arthritis, lupus, and other conditions. And currently, this is not known to be whether this is something that is of clear benefit for people with COVID-19. So we are not recommending that people use this drug on their own to try to prevent themselves from acquiring or treating themselves for COVID-19. At CDC, it's our stance to support the use of this in the setting of a clinical trial. We don't know whether or not yet that there is benefit, but what we have to look at is sort of what comes out of these clinical trials, and it's important to continue to monitor. We are aware that some people have concern that hydroxychloroquine is not available for their autoimmune diseases or disorders, and that is something that is being monitored. Within the federal government, the FDA and the Strategic National Stockpile, which is run out of the Department of Health and Human Services, are aware of this issue, and we continue to monitor this and are aware of this situation. Next slide. So now there's a section that we're going to talk about on what to do. And so many of these guidelines are the same for everyone, but it's important to emphasize the need to be more cautious if you are at higher risk for severe illness from COVID-19. So next slide. If there is a COVID-19 outbreak happening in your community and there is a lot of spread, this could last for a long time. And we classify something as an outbreak when there's a large number of people that are suddenly getting sick. Depending on how severe the outbreak is, public health officials or state and local governments may recommend certain actions to reduce people's risk of being exposed, and these actions can slow the spread and reduce the impact of disease. Next slide. So these are the precautions that everyone should take every day to help reduce spread, and particularly these are important among people that are at higher risk. And I'm not going to read through all of these because I know that we've been seeing these in many different places, but it really is important that everyone play their part in doing this to help reduce the spread. Next slide. So it's also good to have a plan for if you are to get sick. And what we recommend is that if you do have those symptoms that I talked about before, including fever, shortness of breath, and cough, as well as some of those other symptoms, you may want to consult with your doctor about what to do. It's important that you call ahead instead of presenting to a healthcare facility, because again, the hope is that we can reduce spread so that people, so that healthcare providers know that you're coming. If they suspect that you have COVID-19, they may have different instructions for you. And in addition, if you are someone who is at higher risk for having severe illness, that reduces your chance of maybe coming in contact with someone who is being evaluated in that healthcare facility. As there is a lot of spread in a particular community, it's important that maybe you think about other ways to stay in touch with people, maybe staying in touch through phone, through email, other ways of staying in touch with people. And then also, when you're making your plan, try to determine who can care for you if you have a caregiver who gets sick. So if you regularly have maybe a direct support provider or professional who works with you, if there's somebody else, to have a backup plan if that person is to get sick. Next slide. So I think I jumped ahead on my talking points, but this is the instructions of what to do if you do get sick. So stay home and call your doctor. If you are not sick enough to be hospitalized, you can recover at home. And there are instructions on the CDC website that talk about how to care for yourself at home. And I know that the physicians on this call today, as well as your personal physicians, will also have information for you about that. And then, of course, get medical attention immediately if you have any emergency warning signs. So we're not saying you should always stay at home, but but certainly follow the advice of your doctor. I apologize for that interruption. And so on this next slide, you can see some of the symptoms and emergency warning signs to look for. And the reasons why you would want to seek medical attention immediately are if you are having symptoms such as difficulty breathing or shortness of breath, persistent pain or pressure in the chest, new confusion, or if you're caring for someone and they have these symptoms and an inability to arouse them, and bluish lips or face. You can also go to the CDC's coronavirus self-checker if you're unsure what to do, and you'll see a link here on this slide, and you can also go to the main CDC website, which is cdc.gov. Click on COVID-19, and you'll see something that says if you are sick, and there's a self-checker right there, and that will take you through a series of questions that will help you determine what you need to do next if you're not feeling well. Next slide. So here are just some information about how you can take care of yourself while we are all experiencing this challenging time of the COVID-19 pandemic. And I did want to point out the number at the bottom, which is a 1-800 number. If things are very overwhelming for you, there is a hotline that is staffed 24/7, 1-800-985-5990, or you can text Talk With Us to 66746. And there are also other resources on the CDC website on the Stress and Coping webpage. Next slide. So in summary, what we recommend for people who are at higher risk for severe illness from COVID-19 in a time when there is a lot of spread of COVID-19 in your community is to stay at home, wash your hands often, avoid close contact with others, so stay about 2 arms lengths apart or 6 feet, clean and disinfect frequently, touch surfaces, avoid any kind of non-essential air travel and all cruise travel, and call your healthcare professional for advice on managing your own health if you have concerns about COVID-19 and your underlying conditions, or if you're sick. And I think that's the last slide, so I'll turn it back to you, I think, Dr. Diamond.
It was very, very helpful, I think, to all of the listeners. And I'm just reminding all of the listeners that this briefing will be on the website. So all of those sites that Dr. Peacock mentioned where you can get information will be up there on the slide deck, and you will be able to look at them. So at this point, we're going to hear from some practicing physicians. Dr. Aline Charabati, I'll ask to go first, who I mentioned is a gastroenterologist and clinical director of the GI Division and the IBD Center at Sibley Memorial Hospital. So maybe you could tell us something now about what your patients are asking you and what you find the experience of individuals with inflammatory bowel disease in this COVID pandemic. So I'll turn it over to you now.
Thank you, Dr. Diamond, and I really want to congratulate ARDA for putting this amazing program together, and I appreciate the AGA, the American Gastroenterological Association, for inviting me to be part of this panel. My main focus of interest for many years has been taking care of patients with inflammatory bowel disease. Of course, we are getting a lot of questions and concerns from our IBD patients regarding how to manage their disease. Should they take their medication? Should they cut down the dose of their immunosuppressive medication? Should they go to the infusion center? Should they proceed with their scheduled colonoscopy or surgery? So there's a lot of concerns from the IBD community in the face of COVID-19. So we're going to talk about that. But also before that, what I would like to highlight, and Dr. Peacock did a fantastic job reminding us how SARS-CoV-2, so the virus of COVID-19, is getting transmitted mainly through respiratory droplet, and the main manifestation is mainly upper respiratory type of infection manifestation. So the fever, the cough, the congestion, the scratchy throat. But what we are now seeing are also reports of COVID-19 manifesting with GI symptoms. So I want to touch base on that and then go over the general principles in taking care of patients with IBD in the era of COVID. So we've been getting reports that patients who are infected with the virus and have the disease, have COVID-19 disease, can also shed the virus in their stool. Up to 50% of patients who are COVID-19 positive shed the virus in the stool. And this stool shedding can persist up to 5 weeks after resolution of the respiratory symptoms. And again, it can also last more than a week after your respiratory sample is clear. So if we have a patient who has COVID-19, has recovered, if we swab again and we don't find COVID-19 in the respiratory sample, COVID-19 can still be found in the stool. So that highlights the possibility that there could be some orophycal transmission in addition to respiratory droplet transmission of COVID-19. So again, it really highlights the importance of hand hygiene, washing hands, being very careful when you're handling material, washing, the surfaces, and have a very good hygiene at home and outside. The other thing we're noticing now also is that GI symptoms can be present in patients with COVID-19. Up to 50% of patients who are in the hospital because of COVID-19 have GI symptoms. And these vary from, loss of appetite, loss of taste, to nausea, vomiting, diarrhea. Around 18% of patients can have diarrhea. And this can pose a dilemma for our patients with inflammatory bowel disease who typically would have GI symptoms when they flare. So the key message here, if you have IBD, if you have Crohn's or ulcerative colitis, and you develop GI symptoms, it's important to stay in tune, and you know your symptoms the best as a patient. It's important to assess whether these symptoms are different from the typical flare. If you suddenly have vomiting and that was not part of your typical GI flare, typical IBD flare, it's important to recognize that there must be something else going on. So if you have unusual GI symptoms, if the GI symptoms are not the typical symptoms you have during your flare, or if you have fever in addition to GI symptoms, or upper respiratory infection, or maybe a history of exposure, it's important to think about COVID-19 and bring it up to your healthcare provider, your clinician. And for us as clinicians, it's important we start to think about that when patients with IBD are calling us with symptoms. We are starting to think, could this be COVID-19? There have been a few case reports of patients presenting with acute colitis and turn out to be COVID-19. And in one case, the colitis, the inflammation of the colon with bloody diarrhea and appearance of inflammation on CT scan and endoscopy was present without having any respiratory symptoms or fever. So I think we're starting to learn more that COVID-19 can manifest with GI symptoms, with acute hepatitis, with the non-typical upper respiratory symptoms that we have been aware of. Next slide. So I wanted to really go over the general principles when we are approaching our patients with IBD in this era of COVID, and what we know for sure. There's a lot of things we're still learning, and information is continuously updated through GI societies and the CDC and ARDA and Crohn's and Colitis Foundation. So all the main society are constantly updating the information depending on what we're learning. But what we know for now is that the risk of getting infected if you have IBD is similar to that of the general population. What I mean by that is if you have inflammatory bowel disease, that does not increase the risk of getting the virus. If you get in contact with somebody who's infected with the COVID-19 virus, your risk of contracting the infection is similar than somebody who does not have IBD. It is unclear yet if patients with IBD, especially if they are on medication that affect the immune system, are at increased risk of complications or death. There is a registry now in place. It's an international registry that is led actually by UNC and Mount Sinai clinicians, the Secure IBD database. It is open to anyone around the world, and this database is collecting data on patients with IBD who are infected with the COVID-19 virus and have COVID-19 disease. This is absolutely very important to know. So if you have, if you develop COVID-19 and you have IBD, let your clinician know about this registry if they're not aware of it. But for all of us clinicians taking care of GI and IBD patients, when we have a patient with IBD who developed COVID-19, we are enrolling these patients in this registry to help us better understand how COVID-19 affect this patient population. How does it progress? How does it evolve? So far, we've had around 80 patients that are in the registry, and the initial analysis with a smaller number of patients seem to show that patients with IBD progress the same as the general population, meaning the same percentage of IBD patient with COVID-19 will end up having mild symptoms and not need to be in the hospital than the general population, and a similar percentage would require hospital stay or ICU care. In terms of medication, and I'm sure for most patients with IBD, they've heard that before, the biggest evil is always prednisone. So being on a high dose of prednisone does increase the risk of COVID-19 and complications from COVID-19. So that is the drug that we want to try to avoid or minimize. So the overall general principle in taking care of IBD patient in this COVID era is very similar to the pre-COVID era, which means we want to avoid the flare, we want to avoid having to use prednisone, we want to avoid having our patient needing to come to the ER, being in the hospital, needing surgery. So from that main principle, the advice we're giving our patient is to stay on the medication that's keeping their disease under control, whether you are on 6-MP, azathioprine, Tofa, Xeljanz, or on a biologic, infliximab, adalimumab, ustekinumab, vedolizumab. It is important to stay on the medication that's keeping your disease under control to avoid a flare-up that will require steroids, high-dose steroids, being in the hospital or an ER visit. In patients who are on high dose of prednisone, we are doing our best to minimize the duration of high-dose prednisone and to taper down the prednisone to a dose less than 20 milligrams per day. We are recommending for our patient to avoid any of their elective endoscopies. So patients who have longstanding Crohn's or ulcerative colitis, who undergo regular colonoscopy for colon cancer surveillance, these colonoscopies are now on hold because we feel that the risk of exposure in an endoscopy center or in the hospital is higher than the benefit we're going to derive from these screening colonoscopies. But having said that, it's absolutely important to ensure a continuity of care and communication with your physician or nurse taking care of you. So follow up with your healthcare team through televisit, as you usually schedule it. If you usually see your healthcare team every 6 months, 9 months, 3 months, continue that through televisit. Keep an open line of communication so that there's a plan in place in case you flare, what we need to do, how can you optimize the current medication, what can I do in case I run into trouble or if I get exposed or I have symptoms. The main principles are the same for our patients with IBD: social distancing, avoiding travel that's not necessary, work from home when it's possible. And I think for our IBD population or any person with a chronic illness or an autoimmune disease who is already on a tremendous amount of stress, having the chronic illness and being on chronic medication, I think a special focus should also be on the emotional wellness. Diamond and Dr. Peacock said, everybody's under tremendous amount of stress, and it's important to take care of that part in the overall care of our patients with IBD. I will stop there.
Okay, great, because we want some time for the questions from our listeners. That was terrific. So the next speaker will be Dr. Nancy Carteron, who's a rheumatologist and has a major interest in Sjogren's disease. And she will now talk about her experience with patients and her recommendations to individuals with autoimmune diseases, with the autoimmune diseases, the CHICs. So thank you.
Well, thank you very much, Dr. Diamond. And I'd like to also say what an excellent presentation with Dr. Peacock from CDC. Having a little bit of trouble with audio there. Okay, I'll proceed. So what I'd like to kind of review is more from a general autoimmune perspective, not just one individual disease. So in general, autoimmunity is either organ-specific or multi-organ specific. And I think what we're seeing is various responses depending on the specific subset of disease that we're dealing with. So like Dr. Shabati shared, the rheumatology community is also developing an international database. And we will post that information on the ARTA website, COVID-19 Global Rheumatology Alliance. Patients so far, and again, this is a rapid response to get the database up, which is tremendous achievement of scientific and clinical community. At this time, when I checked yesterday, we have 110 patients. And I think it's way too early for us, given the spectrum of the different diseases, to be able to make some interpretation and recommendations. But I do think, at least so far from what we've seen in China and what has been reported, is we are not seeing any particular signals yet, but I would be very cautious because the number of patients in general with autoimmunity that are being captured in the statistics from all countries is small. So I think that these type of registries are going to be very important. At UCSF, our approach at this point in time is also similar to the GI community, to continue with medications that autoimmune disease patients are on and that they're stable. But in general, trying to minimize any of the medications if possible. And so be in close contact with your treating physician. What I would say is that I think the initial research is going to guide us in many of our autoimmune diseases. And I think that what's apparent right now is that there are almost two phases when somebody is exposed to the virus. And so there's the initial viral replication phase, and 80% of people who initially will get infected with the virus will clear it. The second phase, really then in the second week or so, moves on to an inflammatory process. And that also may be affected by immune dysregulation of underlying conditions, including medications that people are on. So I think that at UCSF in our intensive care units, basically when patients are admitted into the ICU, and we've had no patients so far with a primary autoimmune disease that have come in. But in general, the treatments are supportive with, state-of-the-art acute respiratory failure protocols and not any immunomodulation. We have a large number of clinical trials, as many places across the country do, and we would hope that anyone who's in that setting will consider being enrolled into the trials so that we can gain useful information. So I think I'll end there and allow the most time for questions.
Okay, so to answer questions from the listeners, I invite Dr. Charabati, Dr. Carteron, and Dr. Chow from the CDC to join. And I don't know if Dr. Peacock is on still also, but obviously Dr. Peacock. So we've heard a lot about risk and susceptibility. There were many questions about that. I think that those have been largely answered, that to date, with the exception of corticosteroids, there doesn't seem to be increased susceptibility. There was a related concern from several listeners about whether some medications would mask symptoms, including fevers. And really this was how to make sure that you're being tested when you need to be tested, even if you don't meet all of the symptoms, because your medications may mask those. So I'm going to turn that over to the panelists now.
This is a very good question. I think the main medication that we use that can mask fever or pain is really steroids. So prednisone, and especially at higher dose, often can mask a fever or symptoms. Other biologic or immunomodulator do not necessarily mask fever or symptoms. I think the message here is to have a high index of suspicion when there's a new symptom that is unusual, and to discuss this with your physician, your clinician, and bring it out. I think all of us as clinicians are on high attention to make sure that our patients are staying healthy and are not manifesting a COVID-19 type of symptom.
Does anyone else want to address this? I think that was a very good answer.
I agree. I would just say at our institution, we've actually set up a screening clinic. And so for many of the subspecialty clinics, if you're doing a teleconsult with somebody online and you're suspicious at all, you can refer them. They'll be contacted by someone, and then if appropriate, will be brought in to be screening. So again, I think it's making sure you're aware of what your resources are locally on how best to proceed.
Okay, that's very good. So another question raised by many people is, are there recommendations about whether to try to lower doses of any medications, and that would obviously be steroids in particular, or should one just stay on a routine dose? So I'm not sure who wants to answer this.
I'll answer briefly. I think that in rheumatology, we don't really know the right answer, although we certainly, I think, try to minimize medications as much as possible in any setting. In particular with the hydroxychloroquine shortage issue, the American College of Rheumatology actually did come out with some guidelines on that, with giving some parameters or of considering specifically with hydroxychloroquine if person stable, obviously, to consider lowering their dose or stretching out their intervals of dosing.
For patients with inflammatory bowel disease, again, if they are in remission on their current therapy, we don't want to rock the boat. We want to prevent any flare. The International Organization of Inflammatory Bowel Disease put up recommendation that actually patients on immunosuppressive therapy, on tofacitinib, on biologic, should not reduce the dose of therapy to prevent infection risk or to prevent COVID-19. We want our patient to stay on a stable drug regimen that's keeping them in remission and prevent a flare. The one drug we're trying to decrease is the prednisone use.
Okay, that's very helpful. One of the other questions from many individuals is, as vaccines become available, should people with autoimmune diseases be vaccinated? Should they enter trials, or should they wait? Are there specific recommendations for people with autoimmune diseases?
Well, with respect to coronavirus vaccines, I think they're a ways off, even at full court press. Hopefully, and I'm sure we will by that time, have much more of a fuller understanding of the immune system of our autoimmune disease patients with this particular viral infection. So I think it's premature to be able to weigh in on that. I think it's going to also very much depend on what the vaccine looks like and what the antigenicity is. So I understand patients' concerns and worries about that, but I think we'll be able to address some of that later on.
Where will the information that is about patients with autoimmune diseases be available to the public, and when? So we've heard about at least 2 registries, and I'm sure there are many other registries from many other disease-specific groups, physicians and patients who are trying to monitor individuals with that disease. Is there any place one can plan to go to get access to this information, and sort of how much information do you need before it's valid? And maybe Dr. Chow can comment on this because he's an epidemiologist. So, when will we get that information, and how should we assess that information?
Absolutely. Are you guys able to hear me?
Yes.
Yes.
Okay. Yeah, so that's a great question. And, one of the best places that, we try to keep up to date with the most current information is the CDC website. And I believe that that website specific to COVID-19 for both patients and providers is www.cdc.gov/COVID-19. And it actually is a great resource that we, various groups at CDC, keeps up to date based on the most recent information. And certainly new information is collected every day. And we're learning more and more about this disease process as we go along. And so as we know more about specific populations, about specific guidances, we'll continue to update it there.
So there will be a place there to find out about individuals with autoimmune disease.
So as many of the panelists had mentioned right now, a lot of our information is based off of the information that we collect as people develop COVID-19. And so between our partners and between our surveillance systems, we continue to collect that information. And as information becomes available, then we'll make sure to provide the information on our website that may be useful to specific populations.
And
Terrific.
historically, the CDC has done an excellent job about providing information for immunocompromised patients with, cover a wider window. So I think under that umbrella, would likely be where some of the information, but I think specific to specific autoimmune disease subsets, I think the two registries that were mentioned on here for the rheumatology, it's just rheum.covid.org, and they're releasing information via even Twitter. And so I think I think this is a role for the patient-specific organizations, and ARDA as an umbrella for, over 100 different autoimmune diseases to serve as kind of a central, era or window into autoimmunity. So I don't know if you have a comment about that, Dr. Diamond.
Well, you're right, and I think this is something where ARDA is on the ARDA website are the websites for many of the disease-specific information centers, and certainly it will be appropriate for ARDA to be putting this information as we can gain access to it on the website also. It will be very important. So I think that you can look forward to that and be assured that ARDA plans to, as best they can, make this information available to people. So there was another question about whether there are sort of special precautions for people with autoimmune diseases, and really along with that, should people with autoimmune diseases be keeping their appointments or not? We heard that at least one place is recommending against routine colonoscopy. How about infusions?
This is a great question that often comes up with our conversation with patients. Should they go to an infusion center, and whether it's a hospital center or a outpatient infusion center, or is home infusion a safer option? Most infusion centers now, if not all, have put in place special precautions to minimize any exposure to patient of SARS-CoV-2. So in most infusion center, what's happening now is that the patient will get a phone call to be pre-screened for symptoms or exposure, and then patients get asked the same questions when they show up for the infusion. Nurses are taking extra precaution. These are trained nurses in the infusion center who for years are trained to minimize any risk of infection, and are really good about using their mask and hand washing. And also what we're trying to do is to distance patients. So, scheduling less patients during a time slot so there's no crowding in waiting room, putting patients in a separate room in the infusion center as opposed to a, typically sometimes you can have several patients in the same infusion area. So as long as you verify with your infusion center that precautions are in place, there's a system in place to prevent or minimize transmission of COVID-19, we want our patient to continue having their infusion center. It is not clear that having home infusion is safer than going to an infusion center. It's important to remember that the nurses would be going from one house to another to provide home infusion. But in certain situations, that might be the safer option. So it's very important to stay on the medication, on the infusion drugs, if that's what's maintaining your disease, and to discuss with your clinician where it's best for you to receive that infusion. But again, all health organizations are taking extreme precaution to allow delivery of medication to our patient in the safest manner.
So I think one of the themes to answers is to contact your own physician about your own individual situation, because the answer obviously can vary on a case-by-case basis. So what you're hearing now are general principles, but for you in particular, you should contact your physician. Are there, we've heard lots about the fact that we can anticipate a second wave of infection, and certainly people who have been reading up on the 1918 influenza epidemic know that that second wave was more deadly than the first. So is there anything at this point to say about patients with autoimmunity with respect to what to expect going forward, or are we more in a wait-and-see mode?
Well, I think we're going to learn as we go. I think having autoimmunity is such a balance, and many of us, have the experience of hearing from our patients that once they get an autoimmune disease, they often aren't getting other kind of infections. So, it also depends on, what their medications, may be or not. So I don't think we know. I think one thing I learned this week that, we'll be paying attention to is the phenomena that sometimes the second infection, as you may be alluding to, Dr. Diamond, can be worse, and that actually having certain antibodies can make it even more likely to have a significant infection. And so that also raises the issue
Correct.
of passive infusion. But I think that's why it's so important, to be collecting this information in real time to help guide us to make the safest decisions and choices and advice for our patients.
So we've really come to the end of our time. I think this has been enormously informative, and I want to thank Dr. Peacock and all of the panelists, all of the physicians for sharing their insights. I want to remind you again that this presentation will be on the ARDA website, so all of the slides will be available with all of the information of where to go for more information. And ARDA and the coalition partners, the National Coalition of Autoimmune Patient Group partners, will be answering all individual questions. You can imagine that there have been hundreds and hundreds of these, and it will take some time, but they will be answered, and you can access this on the ARDA website, www.aarda.org. So once again, thank you all for this, and stay healthy. Wash your hands and stay healthy. Bye-bye.